have a lot of questions. In fact, we have a ton of questions. And so perhaps we can start to answer some of them. Maybe a question initially for, this is for Dr. Cooke. People are wondering if some of the new CGRP antibodies might be helpful for patients with cluster headache.
The answer depends a little bit on where you live, unfortunately. In the United States, there is one that's been approved for use in episodic cluster headache, and I hope that it will soon be approved in Canada for the same use, because it would be nice to have another option, and certainly, you know, it seems they have very few side effects, so it would be very nice to have another option that we could use here, but at the moment, none are approved for use in cluster headache in Canada.
Actually, if I could jump in on that, they changed the labeling as of about only 2 to 3 weeks ago. Yeah, so in Canada, 𝐒𝐂𝐂𝐑𝐈𝐁𝐄 just received labeling approval for episodic cluster headache, which is a very different dose than what we use in migraine, almost triple the dose. We don't actually have the syringes available yet. So essentially, we're treating patients with samples and keeping our fingers crossed that we'll actually have the proper preparation.
That's great news. Thanks, Mike. I didn't realize that had come through finally.
Thank you. Question for Dr. Knash. Someone is wondering if chronic tension type headaches might be an issue in patients with chronic migraine.
Absolutely. So we'll very commonly see patients will have more than one headache that they suffer. It'd be unusual for somebody to have the exact same headache every single day. So we'll often ask patients to chart every headache they have, but really focus on at least moderate to severe days. And if you saw from the 𝐒𝐔𝐁𝐄 criteria, one is patients need to have at least 15 headache days, but not every one of those days has to be a migraine. Only 8 of those have to be migraine criteria. So we very commonly see them coexist.
Yeah, it's of interest, though, that if you make a diagnosis of chronic migraine, and I agree that many of the headache days in these patients may in fact have a tension type phenotype. If you diagnose chronic migraine, you really shouldn't diagnose chronic tension type headache as well, because officially, at least, the diagnosis of chronic migraine excludes a diagnosis of chronic tension type headache. Chronic migraine sort of is first in the hierarchy. Do you agree with that, Michael? Or
yeah, absolutely.
So here's something which is interesting, and that is someone is asking whether other neuropeptides like substance P might be a target for migraine therapy. So that's an interesting one. And as I recall, some years ago, a substance P antagonist was trialed in a migraine and it was ineffective. So as far as I know, nothing new is happening in that area now. But Dr. Dodick, I think you're still on. Could you comment on that?
Sure, Werner. Yeah, substance P being probably the most potent trigger for neurogenic inflammation, even more than CGRP or PACAP, really drove drug development in the mid to late 90s and early 2000s, and a number of substance P antagonists were tested in migraine, NK1 antagonists, and all failed. So I think the field has moved on and has given up on substance P.
Thank you. Another question which is interesting is, have CGRP antagonists been studied in other pain conditions, for example, complex regional pain syndrome? I don't know the answer. I hope someone else does. Can somebody else jump in?
Well, I can tell you, I gave a lecture at the EFNS last year on this particular topic. And the topic was, what other pain conditions could CGRP receptor antagonists or antibodies be applied to? As you probably know, one has been applied, galcanezumab has been applied to osteoarthritis in a randomized placebo-controlled trial, and it failed. And so I know that there are people looking at this, but to my knowledge, there are no controlled trials underway assessing the effectiveness of any of the antibodies in any other pain condition. But I know people are interested in irritable bowel syndrome, for example. That seems to be one area of interest. And I know fibromyalgia has been brought up as well, but to my knowledge, there are no controlled trials ongoing right now.
Thank you. Dr. Cooke, you've made yourself the local authority on pituitary tumors and headache, I'm afraid. with your very interesting case that I recall very well too. And the question is, could even a very small pituitary adenoma cause migraine or other headaches? And what kind of symptoms might you expect?
So pituitary microadenomas have been associated with 𝐒𝐂𝐁𝐄. I've not personally come across a whole lot in terms of microadenoma causing migraine. I don't know whether Dr. Dodick or Knash or Becker, if you've come across, I think there's probably a spectrum of headaches associated with pituitary adenomas, but the sort of tightest link at the moment seems to be with 𝐒𝐂𝐁𝐄 in the context of the smaller ones.
I think you're right, Dr. Cooke. Miles Levy, when he was working with Peter Goadsby, published some nice papers on this. And the take-home message was that essentially pituitary adenomas can cause a variety of different headaches. You're absolutely right. They seem to be more associated with trigeminal autonomic cephalalgias, but they seem to be associated with a spectrum of headache. And the take-home message is size doesn't matter. And, there's a couple of laboratories, Greg Dusor in Texas and our lab here with Frank Pareca, that have shown that especially prolactin is a potent sensitizer of trigeminal nociceptors, especially in preclinical models and especially in female mice and not in male mice. And so, prolactin secreting microadenomas, we're very interested in that here. And we've been collecting a case series of patients with prolactin secreting microadenomas where you put them on a dopamine agonist to suppress the release of prolactin, and their migraines get better. So I do think there's a relationship here between prolactin and migraine, but there's a lot of work to be done in this area. But we're going to be seeing a lot of research coming out on the relationship between prolactin in particular and migraine.
Thank you. Here's one for Dr. Knash. A question about stimulators for treating migraine, specifically stimulation of the trigeminal nerve. And the questioner mentioned a device called ClearUp. Any comments on that, Michael?
Not familiar with that specific device, but there are different electrical devices out there. The most common one that people might see, it almost looks like a little tiara that goes across the forehead and stimulates the supraorbital branches. A lot of the studies out there, the response rates aren't particularly robust, but some patients do find that they experience less intense pain. There's a lot of non-electrical stimulators as well. I remember maybe a year or two ago, Dr. Dodick reporting on a stimulator that insufflated the tympanic membrane. So there's lots of different ways to stimulate the trigeminal system, and some of them are effective, at least in reducing the perceived intensity of pain. But that specific device I'm not familiar with.
Right, the only one I'm aware of is the cephaly device, which is available. So here's a very important question, and I'm going to make a stab at it. What app, if any, do you recommend for patients to track their migraine headaches? So I want to mention the Canadian Migraine Tracker. It's the Canadian Migraine Tracker. You can just Google that and you'll find it. It's been developed by the Canadian Headache Society, and Dr. LaRue in particular was involved in this, and it's got a lot of good features, including the ability to email your diaries to your doctor. So I would suggest that people consider that one. Anybody else want to comment on headache apps and headache diaries?
I would make one comment. Some of the apps have a really complicated algorithm for measuring what triggers influence your headache. And I know there is a school of thought that spending a ton of time looking at this can lead to sort of anticipatory bias. So if you know that the following 5 things sometimes trigger your headaches, and you know that you've done or been exposed to these 5 things today, there's maybe an element of anticipation that comes from that could actually generate a headache in and of itself. So there's this school of thought around sort of anticipatory symptoms that can come from really focusing on the triggers. And so I think it is good to search for triggers that are modifiable, that you can manage. But there's been some discussion about how some of the apps can be a little bit over focused on triggers with a view of trying to manage what you can around your headaches, which is very important. But not everything is about triggers, I guess, is part of it. And to some extent, we also have to think about not altering our whole life because of a trigger's presence or absence as well, because I think that's just healthy living.
Thank you. That reminds me about COVID, altering our whole life because of a health issue. Anyway, we're getting short of time. There are three important questions here, which I think we should try to get to. Someone indicates, what about DHE? I didn't mention that in my short talk. And what's my opinion regarding subcutaneous DHE for use at home? No, I think it's a good option. One of my first papers on headache was published many years ago on a series of patients who used subcutaneous DHE, dihydroergotamine, at home to treat their headache attacks. And most patients could handle this pretty well and found it pretty helpful. So I guess the bottom line is that triptans aren't being helpful for our patients. Sometimes DHE will do a better job, an older drug, but and a broader spectrum drug. Here's one that I'm going to, and one more thing, a question about what do you give patients over 65 who have migraine attacks? Now, this person wants to avoid NSAIDs because they're not so good for patients over 65 in terms of cardiovascular issues. They don't want to use opioids. So are not triptans the best option for acute headache in Canada for patients over age 65? We certainly use them over age 65. Somebody else want to comment on that?
I think that people are a little bit unduly afraid of triptans. If you don't have cardiac risk factors and uncontrolled hypertension or an allergy to them, they're a reasonable treatment, even if you're older than 65, in my view. Again, assuming you don't have atypical auras, there's warnings about that, although they may not be entirely physiologically based. But we use them. I think there's some hope down the road. Maybe some of the newer agents will also be good options, but a lot of our clinical trials don't include patients over 65, which creates a certain amount of leeway for some of the payers to not pay for the medication in people over 65. And that presents a real challenge for drugs that are costly, particularly as people start to be on a fixed income.
So bottom line is that a lot of us have used them over 65 and people do well if they're otherwise healthy. Here's one that we're going to need a lot of help with, and that is this person has a number of patients who use both CGRP antagonists, I presume the monoclonal antibodies, and untitled toxin A or Botox. So what about this combination? Do people have experience with it, and is it helpful to combine the two? Who wants to have the first stab at that?
So,
I think
clinically, we certainly do the combination when we can. At least in Alberta, what it really comes down to is the payers. So although there's not any scientific reason not to use the combination, many of the payers will make patients choose one agent or the other, just based on the cost. So the monoclonals are going to cost somewhere between $7,000 to $8,000 per year, and one of botulinum toxin will cost about $3,500 per year. So they do not like to pick up the tab for both of them. I know the Canadian Headache Society has been doing some advocacy work trying to talk to some of the Canadian payers to allow that. And there are some studies coming out now showing that there is actual physiologic benefit to the combination.
Yeah, so, Werner, when the antibodies became available in the United States, as you probably know, for a year, patients could access them for free. And because of that, we had the opportunity to try the antibodies in patients who were partially responding to Botox. And we found a significant benefit, actually. And now, of course, as Dr. Knash has alluded to, there's a nice paper that was recently published on the potential synergistic effect where Botox inhibits the release of CGRP from C fibers, and the receptor antagonists or the antibodies target CGRP when they're released, or they target the receptor on the A delta fibers. So because they target two different mechanisms on two different sensory pain fibers, there may be a synergistic mechanism of action. Fortunately, in the US, much to my surprise, several of the largest payers in the country now pay for patients to be on both. We have to sort of jump through hoops, and But they do pay for both. And so I don't think there's any question that patients do get at least a complementary, if not a synergistic effect from the two of them, if they're partial responders to one. The other beauty is that because there's no drug interaction and because their Botox is not really systemically absorbed to an appreciable extent, the side effect profile is really favorable for both by and large. So we have a number of patients on both and doing very well.
Thank you. So I think we've reached the end of our time, but if not, there are a few more questions. I guess Christelle or Rob, just cut in if you think we should stop. Here's a diagnostic question, which I think was directed at Michael Knash. So we heard that headache with a Valsalva maneuver may be a red flag. What about patients who have migraine who find that during a typical migraine attack, a Valsalva makes it worse? Is that a problem?
Well, I think that's Dr. Cooke, so maybe we'll throw that one to her.
Okay, let's send it to her.
Sure. So this is where we have to use our kind of clinical acumen along with our red flag checklists. So if you have a clear established history of longstanding migraines, and we know you have migraines, and a feature of that is that you've noticed when you Valsalva or cough, it aggravates the pain. That would be less worrying to me than someone presenting with a new headache that was hanging around and could be brought on or brought out by a Valsalva. The things we're kind of thinking about when we hear about a Valsalva causing headache or worsening headache are specific conditions where the pressure inside the head is higher, or sometimes certain anatomic variants, such as when you have a sort of saggy brain that hangs down in the canal at the back of the head, like a Chiari malformation. One of the features of migraine is worsening with routine activity, and I think most of us probably Valsalva many times every day when we cough or sneeze or pick something up or bend over. And if you have a headache, it does tend to feel worse when you do that if you're a migrainer. So it's one of those things where you have to use your clinical judgment along with what you know about the patient's history. If this is your first time seeing someone and they've got a Valsalva related headache, then I think you would probably be inclined to image them, look very carefully.
Thank you very much. A nice balanced response. So I want to thank both our speakers. I've just got a text that this is the last question. I also want to thank Dr. Dodick for hanging around. We really appreciate that. And so I think you all helped make a very nice session on headache management and diagnosis. So with that, I'll turn it over to the organizers, and thanks again.